Hypothyroidism is one of the most common medical problems that we come across in the young as well as the old. And to talk on that, we have Dr. Aneesh Ghosh. And to chair the session, we have Dr. C. Jayagumar, HOD Medicine, Sri Gokulam Medical College.
A very good morning to you all. See, actually, hypothyroidism is one of the most commonest topic you hear in all conferences, and most of the doctors feel that we are very competent in treating hypothyroidism, especially physicians. But every talk we get something new, and most of the talks are based on pregnancy and hypothyroidism, and this is a very welcome change. We are getting a talk about hypothyroidism in young and old. That is quite relevant. And we have a very renowned endocrinologist from Ananthapuri hospital. He's a HOD there, and already seen that he has been projected so many accolades he has. If I read all through, I think the time for the presentation will be over. So I welcome Dr. Aneesh to give the presentation.
Thank you, Jagumar sir. I think I'm going to take the challenge. I'm going to give you a glimpse of hypothyroidism in 12 minutes. That is the overview. These cases will speak for themselves. One look, you will get the diagnosis because this is myxedema. The mortality in myxedema coma is 50%. So I am fortunate enough only to see 2 myxedema coma in my entire career of 17 years, because I think we have better awareness. That is the common garden variety Hashimoto's thyroiditis, where you get that rubbery goiter, which is like a pussy cat there, get the firm borders, well defined, it moves up and down with deglutition. Usually they will have the antibodies high, and you treat them with thyroxine for lifelong. This was a challenging case. Actually, at 5 to 6 years, when someone presents with hypothyroidism, if the antibody is negative and there is no goiter, there is no family history, then you know there is something is wrong. It is not in order. The presentation is not in order. Where we looked at the throat, and that is a lingual thyroid. So I have had only 4 cases of lingual thyroid that I have come across in my practice. Having said that, definition of hypothyroidism, it is very simple. Actually, when the TSH is above the upper limit of the reference range, and when the free T4 or total T3, T4 are below the reference range of the normal. How do you get the reference range? You get the Gaussian curve by looking at the hormone levels in normal population. So 2.5 to 97.5th percentile is the normal, that is taken as the normal range. Global scenario, look at India. India is, look at the upper portion of the illustration. You see that hypothyroidism, India is painted deep blue because we have prevalence more than 2%. But thanks to the universal iodization program, by statute in India, only iodized salt can be sold, and our iodine, we are in this iodine sufficiency category. So when there is higher prevalence of hypothyroidism in a geological area where there is iodine sufficiency, then most of the time it is autoimmune thyroid disease or Hashimoto's thyroid. And what are the presentations in infancy? We know prolonged jaundice, poor feeding, hypothermia, constipation, hypoactivity, umbilical hernia, macroglossia, myxedema, horse cry. I am not going into the details. But identifying congenital hypothyroidism is very important now that we have universal screening. But remember, when TSH is more than 40 at any time point in the neonatal phase before discharge, immediate institution of treatment is mandatory. If it is 20 to 40, you repeat the test over 3 days, especially before discharge. It is very important. And in adolescents always look at the height and the cognition, the cognitive functions, psychomotor functions, because these are the two faculties which takes a hit when hypothyroidism goes untreated. Among adults, you see puffy face, reduced hearing, goiter. There is a plethora of findings that you may come across, or signs and symptoms that you may come across: pleural effusion, weight gain, constipation, muscle cramps, cognitive dysfunction, bradycardia, etc., irregular, heavy periods, subfertility. But what are the commonest manifestations? Fatigue, constipation, cold intolerance, weight gain, irregular periods, and subfertility. These are the important clinical presentations that we should take note of. But in secondary hypothyroidism and tertiary hypothyroidism, where the problem is in the pituitary or in the hypothalamus, where these kind of classical presentations are conspicuously lacking. So what would you see? Patient may not be puffy, patient may not have the classical myxodematous picture, they will be thin because there will be coexisting other pituitary hormone deficiencies. They may not put on weight, they may have a small heart if there is coexisting hypoadrenalism. No goiter, usually antibodies will be negative, other pituitary hormones can be abnormal, and in imaging might throw up a mass in the cella. Hypothyroidism in pregnancy is very important. Thanks to our approach nowadays, the guidelines, we do screen for hypothyroidism in the first trimester itself. Remember, the take-home message is increase the dose. The moment a person who is on thyroxine becoming pregnant, then increase the dose 10 to 15% to begin with, and in the first trimester itself, you need to jack up the dose by around 25%, because that is a normal requirement increase which is seen in pregnancy. And also remember, the TSH is ideally kept less than 2.5 micro international units in first trimester and subsequently 3. And in the first 5 months, every month one has to do a thyroid function test. Because of the albumin variability and variability in binding, it is better to do T3, T4, TSH, even though you can settle down with free hormones assay. Etiology, there is a host of, but Hashimoto's thyroiditis, it is the T cell mediated inflammatory response failure which is causing. Iodine is still, we are harping on iodine, because iodine deficiency and iodine excess can cause hypothyroidism. Neck radiation, now with cancer being, the prevalence being skyrocketing, we are often seeing patients coming with hypothyroidism post-radiotherapy, post-thyroid ablation, especially with radioiodine. Infiltrations are not uncommon. We come across at least 2 to 10 cases every year, lymphomatous infiltration or infiltration due to sarcoidosis, other kind of infections like histoplasma, toxoplasma. Medications, remember at least amiodarone and lithium, both can cause altered thyroid function test, because these are the two drugs which we commonly come across in our practice. Endocrine disruptors are altogether a different topic. Central hypothyroidism, always remember, if a patient who's detected to have low normal T3, T4 and inappropriately normal TSH, never jump into conclusions and repeat the thyroid function test in a different lab, especially with good accreditation. Then if someone continue to have low normal TSH along with low or low normal free T3 or free T4 or total T3, T4, then remember it could be hypothyroidism due to central cause. We have picked up n number of cases where you need to have a complete pituitary assessment before you embark on your treatment strategy. Similarly, thyroid hormone resistance. A word about consumptive hypothyroidism, whereas because some pathological entities, this type 3 deiodinase is overexpressed, which catabolize active form of thyroid hormone. So patients will need more and more dose, or patients who are having normal thyroid function can turn hypothyroid. Treatment, congenital hypothyroidism, it is very important. Pick up the case at the earliest. If we usually do the dry sampling, with the blot paper. If that shows an abnormal thyroid function test, immediately call back the patient or the kid who might have got discharged. And the starting dose is always, remember, rule of 10. 10 to 15 micrograms per kilogram body weight is the starting dose. And the first month, every 2 weeks, you do the thyroid function test. In the next 3 months, every monthly, following in the successive next 6 months, every 2 monthly, and keep the TSH in the lower, towards the lower limit of the normal range. That is what I was referring to. Treatment of hypothyroidism in pregnancy. If I have already alluded to you that if someone is a non-hypothyroid, how to deal with such pregnancies. If someone is being detected to have hypothyroidism, start with 1 microgram per kilogram body weight. And always, as I said, it is preferable to do T3, T4, TSH. Even now with the assay, sensitivities have been tremendously improved. We can even look at free T3, free T4, but the albumin and pre-albumin levels are varied in pregnancy. Because of that, you may get some subtle differences. But as I said, do keep TSH well below 2.5 mics in the first trimester, subsequently less than 3 mics. That is what we must do. Then usually there is an incremental requirement, but post-delivery, you please bring back the dose to the pre-pregnancy levels if the patient were on treatment before conception. Then 6 weeks postpartum, one has to do the repeat test. So this is how we look at it. If I think the pointer, will it work? No, I think the pointer is not. Yeah, I think this is not working. Yeah. So we look at the normal TSH there. If it is normal, leave it alone. Low TSH, I told you, low TSH with low T3, T4, always remember central hypothyroidism. High TSH, look at the hormone levels. If it is low, it is overt hypothyroidism. Less than 65, you can offer them kind of over CLS treatment with full dose. That is 1.6 micrograms per kilogram body weight, one go. But if someone is having an elderly citizen that you are dealing with more than 65, 70 years of age, having existing atherosclerotic cardiovascular disease, then you go slow and steady. I think it is better to instead of using that per kilogram body weight strategy, you may start with a fixed dose, 25 micrograms to 50 micrograms, then build up the dose over the next maybe 3 to 6 months and get the TSH normalized so that we can avoid unwanted adverse effects. In pregnancy, I have already said, one can start with 1 microgram per kilogram body weight. In subclinical hypothyroidism, you should not jump your guns and treat everyone having subclinical hypothyroidism because the data is sketchy and scarce. But the bottom line is if someone has a TSH which is more than 10 micro international units per ml, especially young age, less than 65, we have enough and more data to say that there is good clinical outcome in terms of reducing the CV risk and reducing the mortality, so offer them the treatment. If more than 70 years, it is better to hold on, especially if they don't have compelling evidence like dyslipidemia, antibody positive status, family history, head and neck radiation or neck surgery, or history of being on drugs which can cause hypothyroidism or thyroid dysfunction. If such compelling evidences are lacking, then it is better to hold on for a while and wait. Especially in the elderly, you see, if you follow them up, you see that their TSH might settle down in 50% of the time. So don't go by single value, look at a serial thyroid function test readings. And if TSH is less than 10 micro international units and asymptomatic, symptoms have something to do with your decision making, then should you be waiting and monitoring the TSH and thyroid function test once in 3 to 6 months. So the medication, just to, amiodarone has a huge quantity of iodine hidden in it. It can cause altered thyroid function test. Lithium can cause increased intrafollicular iodine. It can interfere with the coupling enzymes function. It can reduce the thyroid hormone output from the follicular cells. Then there is a host of agents which can interfere with the thyroid function, thyroid hormone absorption and its requirements, but I am not going to the details of it. To conclude, ladies and gentlemen, we have hypothyroidism, a clinical condition which is a common disorder in general population. And untreated hypothyroidism, especially overt hypothyroidism, can lead to severe and serious adverse effects on multiple organ systems, both in young and adult. Good clinical acumen and appropriate screening strategy is an important for early detection and effective management strategy. Thank you so much. I hope I finished in time.
Thank you, Dr. Aneesh Ghosh. That was a concise presentation regarding all aspects of hypothyroidism, not only young and old. The topic is open for discussion. Any questions from the House?
Another entity got sick hypothyroid, patient with critical illness, low TSH and low enzymes. I think you may be in a dilemma what exactly to do. So
I don't want to discuss sick euthyroid because whatever that concept that I have given you, I probably will kind of demolish the entire thing if I delve deep into sick euthyroid. But one thing, if possible, people in the intensive care units, people who attends critical care patients, postpone thyroid function test and don't ever do it as a kind of uniform protocol. All patients who are admitted here, we must do an thyroid function test. No, many times you get reports which are very difficult to interpret. So unless and until there is no compelling reason for you to order a thyroid function test in a patient who is receiving critical care measure, and if you could postpone the treatment, the test till the patient is stabilized, I think that is the best. Otherwise, as someone said, you are going to open the Pandora's box. And many times, because sick euthyroid has 3 phases. One is the evolving phase, then is the critical phase, and the recovering phase. All have different manifestations and different propositions, if you look at the hormones. So it is not that easy. Many times we wait, unless there is a huge goiter, unless there is strong family history, unless the antibody is in 3 digits, unless the patient has clear-cut symptoms or signs to say that this patient is hypothyroid, unless and until you don't have compelling evidence, if you are in a dicey situation in the ICU, we hold on and repeat the test 2 weeks. That is all.
A simple question. A simple, straightforward
below
question.
65 years, not above 65.
Very simple question that in the absence of pregnancy, in the absence of pregnancy, primary hypothyroidism, is there any indication for monitoring other than CSH?
You mean you are keeping a patient in follow-up? Not on treatment. No, on treatment.
Primary hypothyroidism on treatment, non-pregnant, is there a role for doing T3 or T4 other?
As a conservative measure, I am with sir. You can manage with TSH alone.
So many people are doing that. Sir.
I know. No. It is a rule of exception which is applied here. If you want to treat someone with T3, there are very few clinical situations which is applicable where you can use T3 along with T4. But if you look at the literature, the data is patchy. It's all small volume trials, and most of the time the data is inconclusive. So as of now, no. T3 toxicosis is an entity which where you get only the T3, which levels are gone. You see that the T4 is inappropriately normal or high normal, and there is inappropriately high TSH and low, T3 and low TSH, which is seen in usually
time is out.
exogenous.
We'll restrict to only one more question.
Just one more, yes. One question is, you will
So
agree.
it is in solitary nodule. It is also seen in exogenous most of the time.
My question is, we know that in the last few decades, everybody is taking iodide salt, but the incidence of hypothyroidism is on the increase. Is it because of autogenic problem or something like that? Just one more question. Is a patient, if you go for a surgery, hypothyroid patient,
Hyper or hypo?
hypothyroid patient,
Hypo.
we take up for surgery, how much is the risk factor involved?
Okay.
Thank you.
What kind of spinal surgery, general surgery, GA?
Under general anesthesia. General anesthesia.
Yeah, if the patient has got good the only problem is the recovery stage of the general anesthesia. If the patient's pulmonary function is good, not a obese hypoventilating patient who is fit, then if the surgery is emergency, if the surgery cannot be postponed, then usually the patient comes out. If the surgery can postpone, if the patient has comorbidities, the pulmonary reserve is not good, the patient is obese, in such situations it is always better to correct hypothyroidism. But taking treatment, a patient who is florid hyperthyroid is riskier than taking a patient who is florid hypothyroid in an emergency situation.
Thank you, sir.